right, let's talk about pertussis. If you're prepping for your exams, you know this one is absolutely high yield. In this first part, we're going to get to know the bacterium, look at its toolkit of toxins, and break down exactly how it attacks the body.
So they call it the 100-day cough, and when you look at this picture, you get why. That terrifying whoop isn't just a sound. It's the noise of a desperate fight for air. To understand how we combat this, we've got to start by looking at the tiny organism that causes all this chaos.
So let's pull back the curtain and meet the villain of our story.
And here it is, Bordetella pertussis. It's been on our radar since 1906. It is incredibly contagious, but here's the absolute key takeaway, the most important thing from the get-go. It is vaccine preventable.
Okay, these are your must-know high-yield facts for any exam. It's tiny, it's gram-negative, and it's a coccobacillus, so, kind of halfway between a sphere and a rod. It's also a strict aerobe, which just means it has to have oxygen to survive. And this last one is really important. It's highly fastidious. That's just a fancy way of saying it's an extremely picky eater and needs a special diet to grow in the lab.
So, how does a bacterium this small and picky cause such a violent illness? Well, the secret isn't its size, it's what's inside its toolbox. Let's look at its virulence factors.
The power of this organism comes from its weapons. It has a devastating 1-2 punch strategy. First, it uses adhesins to latch on, and then it unleashes toxins to completely wreck our body's defenses.
And here is a fantastic mnemonic to lock this in your memory. Just think TAP. T is for tracheal cytotoxin. A is for adhesins. And P is for the big one, the master weapon, pertussis toxin. Let's take a quick look at each.
So the first two really work together. Think of the adhesins as the grappling hooks. They allow the bacteria to stick like superglue to the cells lining our airways. Once it's anchored down, the tracheal cytotoxin comes out. It's like a lawnmower that just shreds the cilia, those tiny little hairs that are supposed to be sweeping junk out of our lungs. With the cilia gone, our defenses are crippled.
And now for the main event, pertussis toxin, or PT. This is the big boss and a huge topic for exams. Its mechanism is a classic, just like cholera toxin. It hijacks our own cell's signaling system, causing a huge uncontrolled surge in something called CAMP. It's this flood of CAMP that causes all the systemic problems in whooping cough. And it's exactly why PT is the star player in our modern vaccines.
Okay, so the weapons are out. The bacteria has set up shop. The infection begins. But this isn't some quick battle. It's a long, drawn-out war that plays out over 3 very distinct stages.
And here's that classic 100-day cough timeline. It moves through the Catarrhal, paroxysmal, and convalescent phases. To remember the order, here's another great mnemonic for you. Just think CPC, as in cough progresses clinically. This table is pure gold for your exams, so let's walk through it. I want you to focus on that first column, the Catarrhal stage. For 1 to 2 weeks, the symptoms are just a runny nose, a mild cough. It looks exactly like a common cold. But here is the absolute most critical point. This is when the person is the most contagious. By the time that classic scary whoop shows up in the paroxysmal stage, they're already getting less infectious.
So what even is that whoop sound? It's a really common mistake to think it's the sound of the cough itself. It's not. It's the sound of the person desperately trying to gasp for air after a long, violent fit of coughing, pulling that breath in against a throat that's partially closed up.
And the sheer force of that coughing is just brutal. The pressure alone can be enough to cause burst blood vessels in the eyes or even hernias. Secondary pneumonia is a huge risk, of course. But the scariest complications, especially for little infants, are neurological. We're talking seizures, brain damage, and even coma.
So, we've met our culprit. We've inspected its weapons. We've followed its battle plan through the 3 stages of the disease. But in the clinic, how do we prove it's really there? How do we unmask it?
Now we're going to do a deep dive on diagnosis in Part 2, but I have to give you a quick preview of 2 classic visual clues that you absolutely have to know. When you grow it on a special agar, the colonies are often described as looking like little drops of mercury. And under the microscope on a gram stain, you can sometimes see this characteristic thumbprint arrangement. We'll break that down more next time.
And all of this leads us to the really big questions, right? We've covered the what and the how of the disease. But what's the clinical takeaway? How do we confirm our suspicion? What are the best ways to treat it? And most importantly of all, how do we stop this from ever happening? We are going to answer every one of those questions in Part 2. We'll get into the specifics of lab diagnosis, run through the treatment options, and cover the vaccination strategies that are our #1 defense. Thanks so much for tuning in, and I'll see you in the next explainer.